If there is one paper A comparison that appears again and again, it's this one. Serotonin syndrome versus neuroleptic malignant syndrome. Both can present with fever, both can present with autonomic instability, both can be medical emergencies, and both are commonly confused in exams. The good news, once you understand the differences, you will never mix them up again. So let's start. This topic appears in neurobiology, psychopharmacology, emergency psychiatry, side effects of medication, and it's one of the highest yield paper A topics. Let's understand the big picture. Think of it like this. Serotonin syndrome means too much of serotonin. Neuroleptic malignant syndrome means too little dopamine. One is caused by serotonin excess while the other is caused by dopamine blockade, and that is the foundation. Serotonin syndrome occurs when serotonin activity becomes excessive, usually after starting serotonergic medication, increasing the dose, combining serotonergic drugs, and common causes include SSRIs, SNRIs, MAO inhibitors, and other drugs like tramadol, linezolid, lithium, MDMA. So how exactly is the onset? And that is probably a major exam clue. Serotonin syndrome develops quite rapidly, and the onset is within hours, sometimes within a day. So this is the exam tip. If it is of fast onset, think serotonin syndrome. Now, what are the clinical features? The easiest way to remember the clinical features is the term neuromuscular hyperactivity. Patients may develop agitation, anxiety, tremor, hyperreflexia, clonus, muscle twitching, fever, sweating. So the most important clue out of all this would be clonus. If the exam mentions clonus, think serotonin syndrome. Let's look at the autonomic features now. Patients may also develop tachycardia, hypertension, hypothermia, diarrhea, dilated pupils. So in order to remember this, just think everything is overactive. Now, as far as management is concerned, obviously the first thing would be to stop the offending medication, provide supportive care, control agitation, treat hypothermia, but at the same time, severe cases of serotonin syndrome may require cyproheptadine. Remember, cyproheptadine is a serotonin antagonist. Now, let's compare. Neuroleptic malignant syndrome, or NMS, is caused by dopamine blockade, and it is most commonly after antipsychotic treatment. Examples like haloperidol, flufenazine, risperidone, olanzapine, although it can occur with almost every antipsychotic. Now, if we try to compare the onset with serotonin syndrome, unlike serotonin syndrome, NMS develops a bit slowly, usually over days to weeks. So exam tip, slow onset, think NMS. The hallmark feature, if we talk about clinical features, would be rigidity in NMS, specifically lead pipe rigidity. Patients may also develop fever, confusion, reduced consciousness, autonomic instability, tremor, but the classic phrase is lead pipe rigidity. Laboratory findings are another important thing and another major clue as far as exam is concerned. So among the lab findings, the most important thing is creatine kinase. So during NMS, creatine kinase rises dramatically. Now, why does this happen? Because severe muscle rigidity damages the muscle tissue. So if you think or if you see elevated creatine kinase during the exam, in the exam question, think NMS. To treat, again the same thing, immediately stop the antipsychotic, provide supportive care. Hydration is very much essential. Some of the medications which can be thought of in NMS would be dantrolene, bromocriptine, and sometimes even amantadine. Let's do a side-by-side comparison quickly. So serotonin syndrome is characterized by fast onset, hyperreflexia, clonus, diarrhea, agitation, and obviously serotonin excess. On the other hand, neuroleptic malignant syndrome is characterized by slow onset, the classic lead pipe rigidity, raised creatine kinase, confusion, and dopamine blockade, usually with antipsychotic treatment. For a memory hack, think serotonin syndrome with shaking, NMS with stiffness, shaking is clonus and stiffness is rigidity. Simple. Let's look at a question. A patient develops fever, agitation, hyperreflexia, and clonus. After starting an SSRI, what would be the diagnosis? It is serotonin syndrome. Now, a patient on haloperidol develops fever, lead pipe rigidity, raised creatine kinase. The diagnosis would be neuroleptic malignant syndrome. It can be a common exam trap when people confuse hyperreflexia with rigidity. So don't confuse hyperreflexia with rigidity, and don't forget serotonin syndrome has a fast onset. NMS is comparatively slower in onset. And those two clues answer many questions immediately. Remember, serotonin syndrome, fast, hyperreflexia, clonus, serotonin excess. NMS, slow, rigidity, raised creatine kinase, dopamine blockade. Master these differences and you will never lose marks on this topic again. Thank you for watching. See you in the next video.